So, a 29-year-old male with no history of prior vertigo or migraines presents to the ER with a sudden severe onset of dizziness, headache, and neck pain, which started about 2 hours prior to arrival. He described his headaches without aura, but he also mentions that about an hour to arrival, he also noted that he visited the chiropractor for a cervical adjustment. He also states that he has no history of hypertension, diabetes, tobacco use, or like illicit drug use. On exam, he appears uncomfortable with a mildly elevated blood pressure of about 140/90, but there's also no nystagmus or dysmetria present, and the remainder of his exam is unremarkable. Initially, I thought his diagnosis would be a vestibular migraine due to like the minor headache without aura and the new onset of vertigo. However, it's also contraindicated because there's no nystagmus or phonophobia present. Now, the correct criteria for a vestibular migraine is to have recurrent episodes of vertigo, prior history of migraines, or at least other symptoms of migraine such as phonophobia, photophobia, or other things like that. And he doesn't meet any of those criteria. So that also lessens the likelihood of the diagnosis being a vestibular migraine. So further tests need to be taken to rule down do not miss diagnoses such as like a cerebellar hemorrhage, an intracranial neoplasm, or a possible vertebral artery dissection. So a normal cranial CT with no contrast is ordered, and it comes back normal, which then lessens the likelihood of a cerebellar hemorrhage being present, which is a good sign. Upon reevaluation, though, he starts complaining of left-sided weakness with flaccid paralysis. These new findings are worrisome, and they also changed my diagnosis to a possible vertebral artery dissection due to him priorly being seeing the chiropractor for a cervical adjustment, which could definitely then precipitate to a dissection of the vertebral artery. So you need to have more testing done to make sure that that is the correct diagnosis. However, as a vertebral artery dissection presents, the normal symptoms are neck pain, headache, dizziness, and worsening neurological findings in which the patient is presenting with. So that also then supports my diagnosis. So I order an MRA would be appropriate in the situation, which then comes back with a positive finding of a vertebral artery dissection, or VAD. And it also shows evidence of a thrombosis in the left carotid artery, the left vertebral artery. So the patient should definitely be admitted because this is a severe situation. So the patient, as long as it's within a 3-hour window of the symptoms, he should be given TPA to make sure that you break down the coagulation of the vessel. And it could be contraindicated because there's a risk of a subarachnoid hemorrhage. However, the benefits of treatment definitely outweigh the risk in this case. The need for blood pressure control is extremely important. So the patient should probably be put on labetalol or some type of beta blocker to manage that. A neurological consult is 100% needed in this case to make sure that you're treating the patient properly. And vital signs should definitely be taken at least twice a day to make sure that the patient's progress is going smoothly. And then along with the vitals, they should also be taking daily neurological exams to make sure that you track the progress of the patient's healing. You should tell the patient that a full recovery takes about 6 to 9 weeks of the vessel to properly heal. So activity level should be normal, but tell the patient to avoid any type of physical activity. Any type of physical contact sport that could possibly disrupt the healing of the vessel. As I said, the normal diet, there's no allergies associated in this treatment, and there shouldn't be any type of procedures or interventions done unless the neurologist warrants that. He seems pretty stable at this point as long as we manage his blood pressure. But after 24 hours of giving the patient TPA, you should start antithrombotic treatment, such as like daily aspirin, to make sure that you decrease the risk of a possible embolism or stroke. So you should also inform the patient that possible headaches and neck pain is common within the treatment process, just because that's just a possible symptom of treating the vessel being ripped open or dissected. So yeah, then also educate the patient on making sure that when the neurologist states that he should be discharged at some point, that he focuses on maintaining his medication treatment to ensure that the risk of thrombosis or embolism or stroke is diminished, because that is the worst complication that could occur. So yes.